Okay, good evening, everyone, and very warm welcome to this this unique ECG course which we are kicking off today. And this seems to be a very exciting and a very well curated ECG course, which is going to run over 5-6 sessions on a monthly basis. So we welcome you all on this session and invite you all for the upcoming session, monthly session on this series. And this is, as I have mentioned, this is a ECG course curated by Dr. Vanitha Arora, Dr. Pawan Suri, Dr. Vivek, and Dr. Viveka. So this is and a very well thought basic course. Start from a very basic and then we'll obviously take on the different aspects of the real life ECGs. So and with me today, of course, none other than Dr. Vanitha Arora and Dr. Pawan Suri. Both of them are here. So we will soon hear a quick comments from them before we start into the session. But a quick introduction from my side to about both the faculties of today. So Dr. Vanitha Arora, of course, is well known across the country for all of you, and she is MD. Internal medicine and DNB from Escorts Hospital, and have been working in electrophysiology for last 2 decades. And Dr. Vanitha is currently Secretary, Indian Heart Rhythm Society, and also President of the IMA Delhi branch chapter, and she is also Vice President of the Indian Society of Electrocardiology. And Dr. Vanitha, as we all know her, is pioneer and very passionate about the cardiac arrhythmia and the treatment around the cardiac arrhythmia. And she has been trained in St. Luke and also in Germany for early part of her career for device therapies. And today she has on her credit more than 3,000 RF ablation and more than thousands of devices she has done. So that's a little bit brief of Dr. Vanitha Arora. Very warm welcome, Dr. Vanitha, for the session, and thank you for curating this session for us. I'm pleased to announce and thank Dr. Pawan Suri, who is a chief cardiologist in SGL Super Speciality Hospital in Punjab. And that's where most of the attendees we think are going to be, the northern part of India. So Dr. Pawan Suri is well-known figure out there. He's, of course, MD/DM cardiologist from SKIMS, Srinagar. And he is a very renowned and a very expert intervention cardiologist. So, and today it will be great blend of having basic electrocardiology along with the intervention cardiology, and that's what the topic and the topic and the subtopics are today. And Dr. Suri is also pretty hybrid in his knowledge and in his practice. He practices intervention cardiologist to the best of level, and he's fairly great experience in cardiac devices as well. And that part of the northern part of the Punjab part of the area also will recognize him as Vice President of Council of the Super Speciality in Jalandhar. So thank you, Dr. Suri, and thank you, Dr. Vanitha. I think we can have a quick comments before we roll out the first talk. Over to you.
Dr. Suri, you want to say something, please?
Yeah, thank you, Albert, and thank you, Dr. Vanitha and Dr. Viveka, for making this kind of a program. It will be a most of an interactive session, and especially the one thing what we are going to discuss in coming months is that part of our investigation which most of the people don't feel comfortable with. So we'll try our best to transfer and to share our knowledge of basic concepts about the ECG reading and how you can read about the arrhythmias and the ischemias and infarctions. Few topics we'll be discussing today. Then a few topics in subsequent months will be circulating or will be showing our program. And if anybody has wants us to add on any topic regarding the ECG, he or she can put in the comment box and we can modify our program accordingly. So I feel it's a very good initiative as far as I am concerned, and I am thankful to both Dr. Viveka, Dr. Vanita, and the Abbott people that they have made me a part of this program. So let us see how it goes on.
Thank you, Dr. Suri. Well, at the onset, I would like to say that this program has been designed courtesy Abbott to take our fellow colleagues together to diagnose the ECG correctly. We are going to be discussing about the basics and the advances in ECG, which means that the basic class as that is of today about the normal ECG, and then subsequently followed by the abnormal arrhythmias, tachyarrhythmias, and subsequently we are planning to follow it with a kind of a live quiz on the ECGs, the clinical practice ECGs that we get. So this program has also been supported, very nicely supported by IMA NDB branch, the New Delhi branch, and the DMA, Delhi Medical Association, for which I am very thankful to both the organizations. And I am especially thankful to Delhi Medical Council, Dr. Greesh Tyagi, for providing us 0.7 points for each CME that we are going to have. So today's CME carries 0.7 points, credit points to all the participants who will be participating today. Henceforth, I think without wasting much time, Dr. Suri has already told you that in case you have any suggestions, kindly put them in the box. We'll take into view. In the subsequent talks, we will have those topics to discuss as per your requirement, and we'll be more than happy to help anybody who wants any discussion, any of the ECG or of diagnosis. You are free to question us at any time. Let this be an interactive session. Whatever you do not understand or whatever you want to discuss further, please feel free to discuss it with us. Thank you so much. And with this, I hand it over to Chandar again for further consideration.
Yeah, thank you both of you, and I think it's a right time. We have right attendance to go ahead. So I invite Dr. Vanita to deliver her first talk in this series, which is basically talking about the normal ECGs, the technical problem, and the variants. So what do we look at normal ECG, and where are the different variants, and that's where all the abnormalities will start looking at. So over to you, Dr. Vanita.
Thanks, Chandar. Thanks for the kind introduction, and thank you for coordinating the session also. So good evening, everybody. I have the pleasure of starting the first session, which will be of the normal ECG, technical problems and variant. See, to diagnose an ECG as abnormal, first we need to be sure what is a normal ECG, and that is the most difficult diagnosis I've ever found in my clinical practice, to say a ECG as normal. Henceforth, we should be aware of how an ECG is taken, whether the ECG has been taken normally or there have been some technical problems in that, and what are the normal variants to a normal ECG. In this discussion, let's move forward and know it all, I would say. So starting with the definition of electrocardiogram, it is the electrical activity which is generated by the cells from the heart, and it reaches the body surface. So recording it graphically on a paper is known as an electrocardiogram. And how is it recorded? Well, we record the ECG with the help of an ECG machine. We know, we have seen the ECG machine, but we don't know is that it is a sophisticated galvanometer, which has a positive and a negative pole in it. Now, once we have the positive pole connected to the lead and the negative pole connected to the lead that is connected to the machine, it analyzes the positivity and negativity and gives us a graph on the paper. A pair of positive and negative surface electrogram constitute a lead which detects and records changes in the electrical potential both in the magnitude and direction between its electrodes. So the magnitude is the amplitude that we see and direction is the linear console on the electrodes. What is the basic principle on which we record a ECG? Well, the net electromagnetic forces, they are directed towards the positive pole. See, when we have a negative and a positive pole, in case the flow of electricity is from the negative to the positive pole, the end deflection will be positive. That means it will be an upstroke. And in case the electrical activity is from the positive to the negative, then the net result will be negative. That means the deflection will be downwards. So this is the basic principle on which the ECG is recorded. And this we have to understand, the positivity and the negativity, which side is the flow of the current, needs to be known to everybody to understand why a certain complex in the certain ECG is reflected like that. So it is very important for us to know this. Okay. So these changes are recorded on a graph paper as a plot of voltage on the vertical axis against the horizontal axis. So this graph has two axes, the vertical axis and the horizontal axis. The horizontal axis gives us the time, the vertical axis gives us the voltage or the amplitude. So each lead provides a view of the electrical activity as seen from its particular position on the body surface. A combination of the lead allows us to see the electrical activity from the various viewpoints. Well, if we have to say it clearly, what it means is that the leads of the electrogram, there are 12 leads of the electrogram. All these leads, they define the electrical activity as they are looking the heart like a at the heart like a camera. So from which direction they are looking at, that's what gives us the amplitude or the graph of the ECG in that lead. I will explain this in more detail. Let's go one step at a time. So we have frontal plane leads, which are lead 1, 2, and 3, and AVR, AVL, AVF. Now out of these leads, 3 leads, that is lead 1, 2, and 3, they are the bipolar leads. That means there is a positive pole and a negative pole. While AVR, AVL, AVF are the augmented lead, and they are actually the unipolar leads. So they are actually the positive poles of the electrodes, and the negative is to the center point, that is the Wilson's point, which you can call it as the negative point or as the 0 point. Now the transverse plane has 6 leads, that is V1 to V6, and all of these 6 leads, the chest leads that we call as, are actually the unipolar leads. So how do we see these leads? How do we place these leads? I'll just briefly tell you that. Well, these are the diagrammatic sketch. For lead 1, it is between the right arm and the left arm. The lead 2 is between the right arm and the left leg. And lead 3 is between the left arm and the left leg. Now, these are the 3 chest leads, the limb leads which are there. The positive in lead 1 is actually the left arm, and negative pole is the right arm. Now, this is how the line is drawn for the lead 1 in the Ithovan's triangle. I can just tell you to remember it very, very easily. Where there is L, that is going to be positive. So in lead 1, L is in left arm. So this is positive. In lead 2, the L is in lower limb. So lower limb is positive and the right arm is negative. And in lead 3, well, you have a left arm and then you have a left leg. So which will be positive? To remember it easily, the left leg has 2 L's. That is why it will be positive and this will be negative. So the complexes in all the 3 leads, the lead 1, lead 2, and lead 3, normally are positive because of the flow of the current from towards the positive pole. Now, these are the three augmented leads, which are, I told you, as the unipolar leads. So the AVR is the right-sided lead because it has its positive pole on the right arm. And to tell you frankly, AVR is the most neglected lead. It is the most left out lead out of the entire ECG. Nobody looks at AVR, which is not a good thing, but yes. And since it is a right-sided lead, the deflection in AVR is always opposite to that of the AVL because they are just opposite leads, because AVL is a left-sided lead. The left forces are stronger than the right side because of the musculature of the heart, which is more stronger on the left side. So, and AVF is on the foot. The left foot is actually the positive terminal. And as I told you, that the second pole, that negative pole or the zero pole, is the center point. That is the Wilson's point here. Now, okay. So this is the diagrammatic Hythoman's triangle as placed on the chest of the patient. The axis is determined by the placement of the leads on in this triangle. The normal axis is -30 to +90. We will discuss the axis in detail in another of the talk, but I will just touch through it because some things are important to understand the normal ECG here, and we will have that right now, the discussion of that right now. So the normal axis is -30 to 90. We take lead 1 and AVF at perpendicular to each other. Lead 1 being 0 and lead AVF being 90 degrees. So in between 1 and AVF comes lead 2, which is at 60 degree. I will come to this once more again. And lead 3 is at 120 degree between AVF and lead 1. Right, and AVR is of course at -150 degrees, and I told you before also, AVR is a forgotten lead. We hardly take care of it. Now, out of all these leads, the 3 limb leads and the 3 augmented leads, actually the boss is lead 2. Why I say boss is lead 2? Because the lead 2, the electrical impulse is actually the vector is in the direction of the axis of the heart. The axis of the heart inside the chest is at 59 degrees. And this lead, I told you, is at 60 degrees. So the amplitude which you see of the vector for the electrical activity in the heart is best seen in lead 2. Coming to the chest leads, well, we have 6 chest leads, which are, I told you, they are unipolar. They have their positive pole at the points where you place them on the chest, and the negative or the 0 point is actually the Wilson's point, which is at the center. Now, where do you place the leads? Well, lead V1 is placed at the 4th intercostal space on the right side. And lead 2 is just placed opposite to that. So V1 and V2 are actually anterior and septum. So they are anteroseptal leads. We go 1 intercostal space down and we place V4 in the mid-clavicular line. In between V2 and V4 comes V3. And V3 is taken as the anterior lead. So it gives you the information about the anterior segment of the heart. V4, in fact, is the anterolateral lead. And V5, we go in the same intercostal, 5th intercostal space. We go in the mid-axillary line where we place V6, and in between V5, 4 and V6 is the V5. So V5 and V6 are actually the lateral leads, giving us information about the lateral segment or lateral wall of the heart. So as we look at it, like a camera, these leads are watching the heart. So 1 and 2, lead V1 and V2 are actually anteroseptal. V3 is anterior. V4 is the anterolateral, and V5, V6 is actually the lateral leads, and they give us the information about the lateral part of the lead. Talking here about the which surface to watch, well, if we look at this diagram, 2, 3 AVF are the inferior leads. They take care of the inferior surface of the heart. 1 AVL are the lateral leads along with the V5, V6, which also give us information about the lateral aspect of the heart. Moving forward, how do we record these ECGs? Well, we record these ECGs on a paper which has small squares. These small squares are 1 millimeter. On the vertical side, we get the information in voltage in form of one small square being 0.1 millivolts, and on the horizontal scale we get it as the time taken for the velocity, which means it is measured as in seconds or milliseconds as we conventionally do. So one small square is 0.4 seconds or 40 milliseconds, and 5 squares constitute 200 milliseconds or 0.2 second. So it is important to know the calibration on the paper, because that will give us lot of more information as we go forward. How is the ECG seen? What are the reflections of the ECG seen? Well, on the recording paper, we see a P wave, we see a QRS, we see a T wave, and sometimes we see a U wave. A P wave is actually representing the atrial depolarization. It gives us the timing, the way that atria is getting depolarized. QRS is the ventricular depolarization. Now, if the atria has got depolarized and it is shown as a P wave, where is the repolarization of the atria? Well, repolarization of the atria occurs when there is depolarization of the QRS and of the ventricle, and since that electrical activity is much of a greater magnitude, so repolarization of the atria is actually embedded within the QRS only. So this depicts ventricular repolarization, while T wave shows us the ventricular repolarization, which is the relaxation time of the ventricles. So during T wave, in case there is an impulse coming on the ventricle, it will not get conducted to the ventricles because ventricles are relaxing at that time. U wave is sometimes seen in the ECG, but it is rarely seen. However, why we see U wave is because of the repolarization of the Purkinje fibers, but it is very rarely seen. Now, what does a P wave look like? A normal P wave has a smooth contour. It is monophasic except in lead V1, where it may be biphasic. And it is normally positive in lead 1, 2, AVF, V4, V6, and it is always negative in AVR. So remember, when I'm telling you in AVR, it is opposite of AVL. So if P wave is positive in AVL, it will be negative in AVR. If complex is positive in AVL, it will be negative in AVR. That's a standard. That's as per standard as we have seen. Amplitude of the P wave, normal amplitude is 2.5 millimeters. Duration is 120 milliseconds, which means 3 small squares. It may be biphasic in V1, which means initial there will be a positive complex followed by a terminal negative complex. So any variation from this normal will be depicted as either P mitraire or P pulmonale. We'll discuss that later on. Now, what is the PR interval? It is from the beginning of the P wave to the beginning and it ends at the beginning of the QRS. So PR interval duration is 120 to 200 milliseconds, and it is the time taken for the conduction from the atria to the ventricles. The PQ segment, that means the from the beginning of the the duration of conduction from the AV node, his bundle, to the ventricles is actually depicted by this PR or the PQ segment that is there. That means we call it a PR segment because in case the Q wave is not present, then we take the first impulse as the R wave. Otherwise, if Q wave is present, then we call it a PQ segment. The QRS complex is the second major deflection in the ECG, which is representing the ventricular depolarization. The normal width of the QRS has to be between 70 to 110 milliseconds. More than 120 milliseconds is the widening of the QRS, as we label it. More than 120 means more than 3 small squares on the ECG thing. The transition zone of the QRS is from V2 to V4, and the voltage in the limb leads is 0.5 and 1 millivolt in the precordial leads. The nomenclature, just giving it, you all know this nomenclature, I'll just touch base with it. The Q wave is the initial downward deflection after the P wave. The R wave is the initial upward deflection after P wave. S wave is the negative deflection following the R wave, and R dash is the second positivity of the QRS complex. Relative size of the QRS are reflected by the upper and lower case letters. I will tell you what that means. This is what that means, that in case you have this pattern, there is a small r and a deep S. This is known as the RS pattern. Now, this is small r, S pattern. Now, in case there are equivocal deflection of the R wave as well as the deep depth of the S wave, then it is a RS pattern. Now, if there is a small S wave, then it is a small S pattern. If it's a completely positive complex, it's a R complex. If there is a small Q wave before that, this is a QRS complex. So similarly, we have different kind of patterns, and this is how we label them as, and you need to know these things. The genesis of the QRS complex, where it occurs with the initial depolarization wave starting from the intraventricular septum, the distal 1/3 of the intraventricular septum, and moving from within the conduction tissue to the lateral wall of the left ventricle and the right ventricle, from the endocardium to the epicardium. That is how the impulse travels. And since the forces, why we see there are heavy left-sided forces, because the muscle on the left side is very thick as compared to right side. Hence the impulse formation is also, it's basically, it is a net result. The vector is from the more stronger on the left side. The Q wave, well, it is an interesting part of the QRS complex. The Q wave is any size in lead 3 and AVR, and it is normal of any size, lead 3 and AVR. A non-pathological Q wave is less than 40 milliseconds in duration. That means more than 40 seconds is a pathological Q wave, and less than 25% of the ensuing R wave in the amplitude. Such Q waves are present in the left precordial leads in about 75% of the normal subjects, and in one or more inferior leads up to 50% of the normal subject, and one in AVL in less than 50% of the normal subjects. The QS complex can occur in V1, but it is rare in V2. So if the QS complex is present in V2, then there is a pathology involved. The word about the R wave, it can be absent in V1, but not absent in V2. It is always present in lead V2. R wave amplitude increases from V1 to V4. The tallest R is usually in V4, followed by V5, and the amplitude of V6 is generally lower than V5. And that is why we calculate, when we go ahead to calculate the voltage and the hypertrophy of the left ventricle, we calculate in V5 rather than in V4 or V6, because the amplitude is maximum in V5. The precordial transition from RS pattern is rightwards to the QR is leftwards, usually occurs between V2 to V4 and is usually an RS complex between V2 to V4. The S1 waves are prominent in AVR. They are large in V1 also and larger in V2. They progressively become smaller in V3 and V6 and are almost absent always in a normal individual in V5, V6. Now the basic component of the QRS is a ST segment. I will just touch base on the ST segment because it will be discussed more in detail by the next speaker because the talk is on acute MI and ischemia, and ST segment becomes the target area while diagnosing the MI or the ischemia. It begins at the end of the QRS and ends at the onset of the T wave. It represents a state of unchanged polarization between the end of repolarization and the beginning of repolarization. That is why it is in a form of a straight line, because there is no flow, there is a zero flow of current during that time. So it's a unchanged polarization time. And it is normally isoelectric and is deviation up to 0.1 millivolt, which means up to 1 square is actually considered within normal limits, but more than that is always abnormal elevation or depression of the ST segment. The T waves, as I told you already, they represent the ventricular repolarization. They are usually smooth, rounded, and asymmetric. The tall T waves, in case they are, instead of rounded, they are tall and peaking T waves, they are a sign of hyperkalemia or digoxin toxicity. We will study about that also in the subsequent lectures. So amplitude up to 0.6 millivolt in the limb leads and 1 millivolt in the precordial leads. Amplitude less than that is normal. They are always inverted in AVR and always upright in 1, 2, lead V4 to V6. They are always upright. They may be upright or inverted in lead 3 and AVL, and usually upright, but can be flat, so slightly inverted in AVF. Upright and inverted or biphasic in V1, at times also in V2, but rarely in V3. So basically what we have to remember is that they are always inverted in AVR and upright, always upright in lead 1, 2, V4 and V6, and in others it can vary even in the normal patients. Well, for the arrhythmologist, a QT interval is a very interesting feature of the ECG. It represents as the duration of ventricular depolarization and repolarization cycle. The QT interval begins at the onset of the QRS complex and ends with the end of the T wave. What is the normal QT interval? Well, QT interval is dependent on the RR interval, hence it always has to be calculated as a corrected QT interval, which is QTC, and it is done easily by the Besset's formula, whereby we take QT interval and divide it by the RR interval square root. The normal QT interval in males is 430 milliseconds and in females is 450 milliseconds. Shivan, can you put everybody on mute, please? There is a lot of background noise. There is a lot of background noise, please. Thank you. So what about the U wave? I told you the U wave is sometimes present in the ECG, and it is the representation of the Purkinje fiber repolarization. It is seen after the T wave, but before the next P wave comes in. It is normally absent in the ECG, but if it is present, it is best seen in lead V2, V3, and V4. Normal U wave vector is oriented in the same direction as of the T wave, and so it will be negative in AVR. And amplitude will be less than 25% of the T wave. What do we know about the QRS axis? We have a separate talk on QRS axis, but I will just tell you briefly that the normal QRS axis ranges between -30 to +90, and the measurement has to be there to, how do we measure it? Basically, identify the lead in which QRS complex is most nearly equiphasic. Identify the lead that is oriented perpendicular to this traditional lead by using the Hexial reference system. And if the predominant direction of the QRS complex in this lead is positive, then the axis is in the same pole as that of the lead. Similarly, if it is negative, it is the same. The direction of the axis is negative. Now, very easy way what we use to see the axis is actually to look at lead 2 and AVF in the ECG. If the lead 2 is positive, or we can look at lead 1 and AVF. That is very, very simple. If you look at lead 1, you look at lead AVF. You look at if both are upright, the axis falls within the normal range. In case lead 1 is negative, then it is the left axis deviation with lead AVF being positive. In case lead AVF is negative and lead 1 is positive, then it is the left axis deviation. And if in case both are negative, then it is the northwest or the indeterminate axis, which is there because both of them are negative. So this is a very easy way of remembering the axis. But if you want to calculate the definitive axis, you have to remember this diagram, mentally remember it, and then you can calculate the exact axis using the formula I just explained to you. The rate and the rhythm are calculated from the ECG strip. The normal rhythm is the sinus rhythm, of course, the God has given us. P wave morphology has to be normal and similar. Well, each P wave is to be followed by a QRS, and each QRS has to be preceded by a P wave. The PP interval has to be constant to have a normal sinus rhythm, and the heart rate varies between, the normal heart rate varies between 60 to 100 beats per minute during wakefulness. This is how the beautiful normal sinus rhythm ECG looks like. Look at the P wave, it is biphasic in V1. The complex has a slight R dash with a deep S in V1, and look at the transition going to V6. There is no S wave, V5, V6. 1 is positive, 2 is positive, 3 is positive. AVR is always negative. It is absolutely mirror image of lead AVL. And that's how a normal ECG looks like. Now, what are the normal variants? What are the variants which are present in the ECG, but you don't have to worry about them because they are the normal variant. One of them, this is a normal ECG. The most important variant is a sinus arrhythmia, which may occur in about, what happens in the sinus arrhythmia is that the PP interval, it varies for more than 10% with acceleration of the rate during inspiration and slowing down during expiration. And this is how it looks like, but you have to see how much is the variation, and you should not label it as the abnormality of the sinus rate. It is a normal variation if it occurs with breathing and with slowing down of the expiration. Athlete's heart is a very interesting study altogether. Athlete's heart have a slower heart rate, that is sinus bradycardia is normal. Even first degree AV block is normal in an athlete heart. There are increases in the QRS voltages because of the thickening of the left side of the muscle, the left ventricle muscle. There are increase in the QRS voltages. There are labile T waves, which may be either inverted or biphasic, and the Holter may show even up to Wenckebach, that means second degree type 1 AV block with junctional escape rhythms, that means the sinus node may be slow. So these are normal variants present in an athlete's heart, and we have to know these. However, the changes become less pronounced or they even disappear in case the training is stopped. So these are totally reversible changes. Please do not go ahead and give pacemakers to such patients. Try to have them get out of the training programs, and these all changes will reverse. The early repolarization occurs in 1 to 2% of the general population. especially in males. They are also common in athletes. There is a small concave, there is a little concave upward ST segment elevation and prominent J waves in the mid-precordial leads, often with the tall T waves, and they are associated with the slow sinus rate. And these are the normal early repolarization changes. Look at this ST elevation, the slight smooth moving up of the STJ point elevation, we call it, which is present. But this is a normal variant and is known as the early repolarization abnormality. There can be some persistent juvenile pattern in the ECG in form of T-wave inversion in the right precordial leads V1 to V4 and in the early childhood, and they may persist up to adulthood, which are seen in this ECG. The RSR pattern in V1 is seen with the normal QRS duration in about 2.4% of the healthy individuals. Now, there can be some technical problems. I'll quickly go through this so that I can close the session in time. There can be sometimes the main AC interference, which can come as the noise of at the baseline ECG here. You see there is a noise. This is because of the alternative current interference with the ECG machine. So you have to correct it. You have to correct the leak and take the ECG again, because this is not abnormality of the ECG. This is the technical variation. Sometimes the baseline can be wandering, and you see with the respiratory movement, the baseline is heading up. Lead 3 has a good baseline, but lead 1 and 2, AVR and AVL have a wandering baseline. So this is not an abnormality, this is an artifact. And there are in patients who have Parkinsonism or some kind of muscular dystrophies, you can have this kind of tremors, muscle tremors, which may be seen in the multiple leads, but you have to learn to decipher out this noise from the actual ECG abnormality that the patient may have. Well, if you look at this ECG strip very carefully, you see there are well-formed QRS complexes here. You see this RR interval, and there is a QRS complex here. There is a QRS complex here. There is again a QRS complex here. So there cannot be a well-formed QRS complex in between an arrhythmia, which is as malignant as VF, which is occurring. So these has to be a artifact rather than a actual arrhythmia which is occurring in the patient. And you cannot have a good well-formed QRS complex in one lead while the corresponding leads are showing a abnormality of the rhythm. This is not possible. If one lead has a QRS, then that QRS has to be present in the other lead also. If it is abnormally present, that means this is because of the artifact of the lead. This is how, however, is the actual arrhythmia. The preventricular, there is a complete heart block going on, which is leading on to the monomorphic, non-sustained monomorphic ventricular tachycardia in a patient. So artifacts can be of different types, which can mimic the and confuse you as a real disease. You have to look at the patient's symptoms and the hemodynamics before labeling those artifacts as the arrhythmias. Normal ventricular complexes can appear in between that artifact, so we can be very sure about it that it is an artifact. If it is associated with the body movement, you have to know how to differentiate it. And the instability of the baseline tracing during and immediately following the alleged arrhythmia has to be seen. And there is to be synchronous visible notching consistent with the underlying ventricular rhythm marching through the pseudo-arrhythmia or the artifact that is seen on the ECG at times. So thank you very much for your patient hearing. I request Thakur to please proceed with the next talk, and then maybe at the end of the session, we can have some discussion. I will stop sharing my slides. Okay, here it is. Yeah.
Yeah. So thank you so much, Dr. Vanita, for such a wonderful.
Can you put everybody on mute, please?
Yeah. Okay. So with that, we will now move to the second topic. It will be presented by Dr. Pawan Suri. So over to you, Dr. Suri. You can.
Are my slides visible?
Yes, sir. You can just put them in full screen and go ahead with the session, sir.
Is it okay?
Yes, perfectly fine.
Thank you, Dr. Vanitha, for giving a wonderful overview of the basic ECG and the various variants and the normal variants which we should be very careful of while we are dealing with the ECG. So as I have been asked to talk about the ischemia and infarction identification on an ECG. So the first thing that comes to my mind, as Dr. Vanitha has already said in her concluding slide, that any definitive interpretation of ST wave changes without the correlation with the clinical data and serial tracings is hazardous and unjustified. So there's a very incident which happened while I was doing the residency. So after our rounds, we just were walking in the corridor, and one of our junior colleagues came with an ECG in his hand and said, "Sir, please have a look on this ECG." And that was an anterior wall MI. So out of an enthusiasm and when you start learning an ECG in the initial stages, you become very enthusiastic about reading it. So I said, "Oh yeah, it is an anterior wall MI. Go and see the hemodynamics of the patient. I will be coming." So without knowing that, my boss, my guide was besides me, and he said, "Dr. Suri, he has come for an opinion, and you have given a decision to him. And before giving the decision to anybody, you should take an evidence of the corroborative evidences also." So that was a teaching, the first teaching which I got when I interpreted an ECG. So once you are reading an ECG, so we will be discussing the ECG in the coming months also, and today also for half an hour I'll be discussing about an ECG. So the information what I got at that point of time is that don't believe in any investigation in a singular way. Take the corroborative evidences, read the patient, correlate it with the other investigation, and then give your opinion when you are in a position to give your opinion. So as I have to talk about the ischemia and infarction localization, the coronary artery and the area of supply is very important. And as we know that we have the left main coronary artery, and we have two main vessels on the left side, the left anterior descending and the circumflex, and on the right side we have the right coronary artery. So before going into the understanding of how to interpret or how to localize the vessel on the basis of an ECG finding, it is important to understand the area of the supply. So left main coronary artery supplies the anterior left ventricle, left atrium, and except the posterior portion of the interventricular septum and the adjacent area when the PDA is from RCA. So LAD supplies the anterior two-thirds. Please unmute here, Shwin. So LAD, it supplies the anterior two-thirds of the interventricular septum. It supplies the anterior portion of the left ventricle and whole of the apex. So D1 is the first diagonal branch of an LAD. It supplies the high lateral wall of left ventricle, and D2 supplies the lower lateral aspect of the left ventricular free wall. The first septal supplies the superior and the anterior portion of the interventricular septum, and ramus intermedius, which is the vessel on about 30 to 40% of the patients. And this is the vessel which comes between the LAD and the circumflex, and it supplies the anterior aspect of the apex. So left circumflex supplies the obtuse margin of the heart, the entire posterior wall, left atrium, and the posterior interventricular septum if the PDA arises, if it's a dominant LCS, if the PDA arises from it. So PLV, it supplies the posterior and the diaphragmatic LV, and the PDA, it supplies the posterior interventricular septum and the diaphragmatic LV. On the other hand, the right coronary artery supplies the right atrium, the part of the left atrium, the right ventricle, the posterior superior interventricular septum, sinus node, and the AV node. And the acute marginal branch, which is one of the branches of the RCA, it supplies the inferior and the diaphragmatic surface of the right ventricle. The conus branch, the sinus nodal branch, the RV branch, they supply the electrical system of the heart. So when we have to localize, or when when we look for the localization summary, we should remember it as the left coronary artery as the slab. That means the left coronary artery, it can produce the septal MI, it can produce the lateral wall MI, it can produce the anterior wall MI, and in some cases, it can produce the inferior wall MI. The right coronary artery, on the other hand, it causes the right ventricular infarction, it can cause inferior wall MI and the posterior wall MI. So the acronym for this left coronary artery is the SLAP and the right coronary artery is the RIP. So these are the evolutionary changes when we follow the patients of acute MI, the ST elevation MI. These are the evolutionary changes which we see in an ECG. We first of all find the tall T waves, then we find this ST elevation, the abnormal Q waves come in later on, and then there is this decrease of the ST elevation with the beginning of the T wave inversions, and finally the isoelectric ST with the symmetrical T wave inversions. So this is the sequence of events or the evolutionary changes what we see in a patients of an evolving acute MIs. So since we have an ischemia and infarction, the ischemia is a milder form of an infarction. And when we talk about the myocardial ischemia, it is very difficult for us to localize an artery or localize the culprit vessel on the basis of the myocardial ischemia. So on the myocardial ischemia, the ECG will usually have a symmetrical or deeply inverted T waves. It can have the horizontal ST segment depression with or without the T wave inversions. It can have the non-specific ST and T wave changes, or there can be the normalization of the abnormal T waves, like the patient has already an abnormal or the inverted T waves, and we can have an ECG with a normal T waves. So that can also be a part of a myocardial ischemia, provided we are able to correlate it with the clinical symptoms. So this is what I want to show is that there can be an ST depression, the horizontal or the downsloping ST depression can be there. There can be the T wave inversions. It can last for minutes or hours or days. And if the patient is having a continuous angina or the unstable angina or non-ST elevation MI, it can persist for a longer time. But this T wave inversions and the ST depressions, we cannot be able to localize the culprit artery on the basis of the ST or T wave depression. So in case of the myocardial ischemia, it is very difficult to localize the culprit artery. So what mostly we will be discussing in the coming slides for another 20-25 minutes is about the ST elevations and its significance as far as the localization of the artery is concerned. So ST elevation is usually seen in leads facing the MI. Like if we have an anterior wall MI, we will have the ST elevation in the precordial leads. We have an inferior wall MI, we will have the ST elevation in the limb leads, or like that, which we'll be discussing. So it can be seen ST elevation is the degree of ST deviation, it may vary. And it has been seen that in inferior wall MI, they resolve within the 2 weeks in 90% of the patients. And in anterior wall MI, they resolve within 2 weeks in 40% of the patients. And in rest of the case, it may persist for 1 to 6 months. And we may see an ECG with elevated ST segments, and they may be having an LV aneurysm, which we'll be discussing later on. So this is an ST elevation and myocardial infarction location. We can have the lateral wall MI. If we have an ST elevation in the lead 1 and AVL, we can have the inferior wall MI if we have the ST elevation in the 2-3 AVF, septal MIs in V1 to V3, anterior wall MI V3 to V4, and lateral wall MI V5 to V6. So in some cases of where we have the ST elevations, we can have the reciprocal ST depressions as well. And it is more pronounced in the patients who have an inferior wall MI as compared to the anterior wall. And the conventional explanation for the ST depression is the electrical phenomenon, which Dr. Vanita has already discussed, that it is actually the electrical vectors which are represented on the ECG, and we are interpreting those vectors only. So the other explanations is that the patient may have an ischemia at a distance, what we call the ischemia at a distance, like the patient have an inferior wall MI in the RCA territory, and this can be ST depressions in the anterior leads, meaning thereby maybe the patient has an associated double vessel disease or here involvement of the other vessels as well. So this is what we call the ischemia at a distance. Or the patient may have a more extensive myocardial infarctions, and it may be producing the vectors so that there may be depressions in some leads and there may be the elevations in the opposite leads. So Q wave already has been discussed. So the typical ECG pattern when we are talking about the myocardial infarction is everybody of us knows that more than 2 millimeter ST segment elevation at 60 milliseconds after the J point in anterior precordial leads and more than 1 millimeter in other leads. And it should be present in 2 or more than consecutive 2 leads. So this is the definition of acute MI, or if we don't have such findings, any change, or when we compare it with the previous ECGs, if there is any significant change in the ST segments, we should take into consideration that patient is having an acute coronary syndrome. So one is the anterior wall myocardial infarction, and most of us know that it is because of the left anterior descending artery. It has got the worst prognosis, and worst prognosis because the larger myocardial is at risk, so larger infarct size and patients can. So the magnitude of the reciprocal changes in the inferior leads is determined by the magnitude of the ST segment elevation in the lead 1 and AVL. So it may be absent in the anterior ST emission that do not have the lateral wall involvement. So this is the precordial, how the anterior wall MI can be classified on the basis of the ST segment elevations in the leads. In the precordial leads, we can have the septal MI when the ST segment is elevated in the lead V1 and V2. We can have the anterior wall when the ST segment is elevated in all the precordial leads V2 to V5. We can have the anteroseptal when there is ST elevation in V1 to V4. We have the anterolateral when we have the ST elevation in lead V3 to V6 as also 1 and AVL. And we can have an extensive anterior anterolateral wall when we have the ST elevation in V1 to V6 plus the lateral leads of 1 and AVL. So when we are talking about the left side, the first the thing what we need to discuss is about the left main coronary artery. So if there is an occlusion of the left main coronary artery, there will be a widespread horizontal ST depression, and it will be most prominent in leads 1, 2, V4 and V4 to V6. So there will be an ST depression. So don't miss it with the non-ST elevation MI. You have an ST depressions in the lateral leads. You have ST depression in V5, V6 in lead 1 as well. But if you look at the lead AVR, which Dr. Vanitha also already talked about, this is one of the most neglected lead, but it is the most important lead. The neglected as well as the important lead as far as the interventional cardiologist is concerned. And you can see there's an ST elevation in the AVR. So once you correlate, or once you correlate this elevation with the depression in the lateral leads, so this gives an idea that this patient is having a left main coronary artery involved. So any ST elevation in AVR more than the V1, one should think about the left main. So the basic difference between the proximal or the ostial left LAD involvement and the left main involvement is that you have to compare the ST elevation in lead AVR with the ST elevation in lead V1. If the ST elevation in lead AVR is more than V1, then you should think of the left main. And vice versa, if the ST elevation in lead V1 is more than lead AVR, that means the left main is spare, and it can be the proximal LAD. So that is the significance of the lead AVR and V1 when we are differentiating between the left main and the proximal LAD. So ST elevation in AVR is not entirely specific to left main coronary artery occlusion. It may also be seen with the proximal LAD occlusion, maybe some clot at the distal end of the left main as well. And it can also be seen in severe triple vessel disease. So ST elevation in AVR, if along with it, if it is associated with a diffuse subendocardial ischemia, producing the reciprocal changes in the lateral leads, one should think about the left main. So when we talk about the predictive value of ST elevation in AVR, in the context of widespread ST depression plus symptoms of myocardial ischemia. So ST elevation in AVR more than 1 millimeter, proximal LAD or left main coronary artery occlusion, as we have talked about. But if it is, and if the ST elevation is more than 1 millimeter, one should always think about going for the bypass surgery rather than going for the stenting. And this ST elevation in AVR, it differentiates the left main coronary artery from the proximal LAD occlusion, as already discussed. So coming down from the left main to the LAD, the two signs or the two syndromes which are very important, which often, we misdiagnose when we watch these signs, is the Wellen syndrome and the Deventer's waves. So the Wellen syndrome is a classic T wave in V2 to V3 during pain-free period. And once you see or once you tune your eyes to such wave patterns, you cannot miss it. And this Wellen's waves or the Wellen's sign, it is significant of the high-grade stenosis of left anterior descending, and 75% of the patients, they develop myocardial infarction within a week. We have seen number of times the patients coming with the chest pain in an emergency. We get an ECG done during the chest pain. The ECG is normal. Send the patient back, and after 3 days, 4 days, the patient comes with full-fledged MI. And then when we, correlate it with the previous ECGs, we find that yes, we have missed something. So this is one of the signs which is usually missed by most of the people, but if once remembered, you cannot miss it. Similarly, the Deventer's waves, it was first of seen in 2008, and it is again almost the same. But here, what happens is that there is an ST depression and peak T waves in the chest leads, and it is seen in 2% of acute LAD occlusions. And this is one of the areas which can help us in localizing the culprit artery even when there is an ST depression. And that's why some authors, they say that it should be considered as the STEMI equivalent. So this is the diagnostic criteria for the Wellens. You have a progressive symmetrical deep T wave inversions. You can see there you have a bifid T wave, or you have a T wave inversions in V2 and V3. And there is little or no cardiac marker elevations. There are no significant ST segment elevations. There is no loss of precordial P waves. You can see there are small R waves here. So there is no loss of the precordial R waves. So this, if you see such kind of an ECG or such kind of a sign in an ECG, and the patient is having a chest pain, not necessarily at that point of time the patient will be having a chest pain. The patient may have no chest pain, but you find an ECG and patient has a history of chest pain, you should keep in consideration or keep a watch on the patient or take him to the cath lab for the angio. You can see these are the type A and type B types of the Wellen syndrome. You can see V2 and V3. There's a symmetrical T wave inversions, and you can see here's a bifid type of T wave. So you can have both the patterns of the Wellens in patients who are having the anterior wall MI. So this is the slide I have deliberately put in. This is the patient who has come into an emergency with a chest pain, but you can see there is no significant ST T wave changes in any of the leads. So this patient has been sent home, but later on this patient came in an OPD after 24 hours. After I feel 16, 18 hours, he came in an OPD with no chest pain, but he was told at this point of time that you have to follow the cardiologist in the OPD. So he came next morning, he came in an OPD, and you can see the change in the ECG. So, and the patient was not having the chest pain at this point of time. And we did an angio in this patient, and it was a proximal and LAD 100% block. So this is the significance of V2 and V3 in the patients who have a chest pain and you are suspecting the LAD involvement. So when we talk about the left coronary artery and it's, we want to localize the level of the blockage, we need to understand the anatomy of the LAD also. You can see the left main is here and LAD has come out. This is the diagonal branch, and then this is the septal branch. So any blockage here between the ostial LAD and the diagonal branch, or it will be considered as a proximal LAD. After the D1 to D2 is the mid LAD, and below the D2 will be the distal LAD. So occlusion proximal to the S1, that is the the first septal branch. So there will be an ST elevation in AVR. There will be ST elevation in V1 more than 2.5 millimeter. So if a patient has a proximal LAD involvement, and you can have an ST elevation in both the AVR as well as the V1, but V1 will be having a more higher ST elevation as compared to the AVR. Or secondly, the patient may present with the right bundle branch block with ST depressions in the lateral leads. So this is the patient having a proximal LAD involvement before the septal branch. You can see the RBP pattern of pattern C in the V1, but associated with that there is an ST elevation as well. So this is an acute onset or a new onset right bundle branch block with chest pain with T wave inversion or ST depressions in the inferior leads. So this is a ostial or a proximal LAD involvement, and this is one of the ECGs which should be taken care of as immediately as possible. So ST elevation in AVR of any magnitude is 43% sensitive and 95% specific for LAD occlusion proximal to the S1. So a patient having a right bundle branch block or the patient having an ST elevation in AVR should be considered, should make you think about the proximal LAD occlusion. So occlusion below the first septal and the first diagonal. So from the septal we have come down between the first septal and the first diagonal. What will be there is that there will be the ST segment elevation more prominent in the V3, V6 than V2. So once there is a ST elevation more in the distal precordial leads like V3, V4 as compared to the V2, so that will make you understand that it is having a more distal obstruction. So if a patient having an ST elevation in V1 and V2 and another patient having an ST elevation in V3 and V4 more than the V1 to V2, you should think that there is an LAD involvement, but the occlusion is distal, is moving distal towards the apex. So this is an algorithm what we should follow in patients of ST elevation in anterior precordial lead, in the precordial leads. So ST elevation in V1 to V6, LAD occlusion should be suspected. Immediately we should have a look on the inferior leads, lead 2, 3 and AVF. If there is an ST depression in lead 3 and AVF more than 2.5 millimeters, so you should think that the obstruction is proximal to the D1. So a patient having an anterior wall MI with reciprocal changes in the inferior leads, significant reciprocal changes in the inferior leads, you should think that the obstruction or the blockage is proximal to the diagonal. At the same time, if there is an ST elevation in the AVR or there is an associated right bundle branch block, so obstruction becomes more proximal. So it becomes more proximal before the septal. And if there is an ST elevation in 2, 3 AVF or if there is an ST equivocal, there is no effect on the ST segment in inferior leads in patients of having an anterior wall MI, then you should think that this occlusion is distal to the D1, that is in the mid LAD. So proximal LAD, you should right bundle branch block, reciprocal changes, anterior wall MI, and more elevation in the V1. That means the patient is having a proximal blockage. Anterior wall MI, ST elevation in the anterior segments, no changes or minimal elevation in the inferior leads also, then one should think about that the patient is having a obstruction or the blockage in the mid LAD beyond the diagonal one. And when we talk about the sensitivity and specificity, if the patient has a right bundle branch block and there's an ST segment elevation in V1 more than 2.5, the specificity that the proximal LAD is involved is 100%. So from an ECG only, you can make out that how this patient is going to behave at the cath lab, what kind of support do you want in the cath lab, and how his hemodynamics are going to be taken care of while you are doing the procedure. Similarly, if there is an ST segment depression of more than 1 millimeter in 2, 3 AVF, again it signifies that the patient has a proximal LAD involvement. On the other hand, if the patient is not having any ST segment depression in inferior leads, then you should think about that the patient is having a distal LAD involvement, and you can just take your time and deal with the patient accordingly. So the LAD, what we talk about, we have different types of LADs, the type 1, type 2 and type 3, and this wraparound LAD, what we call the type 3 LAD. So it's a larger LAD, a longer LAD, and it winds around the apex and goes up to the posterior wall as well. So that's why it's called a wraparound apex, because it wraps around the apex of the heart. So there will be the simultaneous ST segment elevation in inferior and the anterior leads in this kind of a LAD involvement. So you can see there's a patient of the wraparound LAD, you can hyperacute T waves in the anterior leads, you can see, and at the same time you see an ST elevation in the lead 3 as well. So this type of an ECG with the presentation of acute chest pain should make you think that this patient is having a very large LAD, a very long LAD, and it should be taken care of as early as possible. So apical infarction should be considered or should be kept into consideration when both the anterior as well as the inferior leads show ST elevation, and the culprit vessel should be the wraparound LAD. Though we have in some cases the RC involvement also, I will show in the slide later on how we should how we can differentiate such kind of LAD from the RCA. And this is one of the, the patients, if you see this kind of an ECG of an acute MI, especially an acute anterior wall MI, you should give a very grave prognosis to the patient, because this kind of an ECG gives you a clear understanding this patient is going to be in the cardiogenic shock, the ejection fraction is going to be less, and this type of an QRS pattern or the ST segment deviations is known as the tombstoning pattern. So this suggests an extensive anterior wall MI, and the survival changes are very less irrespective of whatever procedure or whatever management you're going to give to the patient. So coming from the left main and coming from the LAD to the inferior wall MI, the inferior wall MI or the inferior STMI, we can have either because of the CIRC, LCX, or because of the RCA. So it contributes about 40 to 50% of all MI, a more favorable prognosis as compared to the anterior wall MI, and in hospital mortality is about 2 to 9%. So up to 40%, they have a concomitant right ventricular myocardial infarction, and this adds to the prognosis. If the patient has an inferior wall MI, along with that, there is a right ventricular myocardial infarction, the prognosis worsens. And in 20% of the patients, they have a significant bradycardia due to second degree or third degree heart block, and it also increases the hospital mortality by 20%. And if the inferior wall is associated with the posterior infarction, again, the prognosis is worse. So how we make out the inferior wall MI is that we look for the inferior leads 2, 3, and AVF. So the inferior wall MI can be produced because of two vessels, the right coronary artery and the left circumflex. So how to differentiate between the right coronary artery and the left circumflex is, if the ST elevation in lead 3 is more than lead 2, this goes in favor of the right coronary artery involvement. If the ST depression in lead AVL is more than ST depression in lead 1, with ST depression of more than 1 millimeter in lead 1 and AVL, then it again goes in favor of right coronary artery. If the ratio of ST depression in V3 to ST elevation in lead 3 is less than 0.5, so when we are talking about the ratio of the ST depression in V3 to ST elevation in lead 3, if it is less than 0.5, it goes in favor of the right coronary artery. And if there is a decrease in R wave amplitude and an increase in the S wave amplitude with an S to R ratio of more than 3 in AVL, so this again goes in favor of the right coronary artery. So these are the 4 parameters by which you can make out that the patient is having a right coronary artery involvement. And more importantly, in more than 95% of the patients, if the patient has an associated right ventricular myocardial infarction, so you should keep into mind that it is going to be the right coronary artery, because only in 4 to 5% of the patients who have a right ventricular myocardial infarction, it is caused because of the left circumflex. So these are the 5 points which, in case of an inferior wall MI, which give you an idea that this patient is going to have a right coronary artery as the culprit vessel. Similarly, the points which are in favor that the left circumflex is causing the inferior wall MI is that if the ST segment elevation in lead 2 is more than lead 3, if the reciprocal ST depressions in V1 to V2 or the posterior wall MI because of the obtuse marginal involvement, so patients of the LCX involvement who present with inferior wall MI, if they have an associated posterior wall MI, then think of the CIRC involvement. If the patients of the inferior wall MI having a right ventricular involvement, think of the RCA. So this is another differentiating point between the two. The ST elevation in V4 to V6. Okay, the ratio of ST depression in V3 to ST elevation in lead 3 is more than 1.2. So if it is, the ratio is more than 1.2, we should think that the left circumflex is the culprit vessel. ST depression in lead AVL is less frequently seen, so the STT changes in the lateral leads is less commonly seen in the LCX. And if the S to R ratio is less than 3 in AVL, then we should think about that the patient is having the left circumflex involved. So this is again showing the same thing. You have an ST elevation in lead 3 more than lead 2, and then you have the ST depression in lead 1. This signifies that the patient is having an RCA involvement. You don't have the ST depression, but you have an isoelectric ST, or you can have a mildly elevated ST in lead 1 along with the inferior wall MI. This gives you an idea that this patient is having a LCX involvement. So this is again showing the same thing, the RCA involvement. You have a lead AVL ST depression along with the elevation in this, and you can see the RVMI also here, but you have not done the right ventricular leads, which we'll be discussing in coming slides. So the right ventricular infarction, it is the subtle and easily missed. As we talk about the ECG, AVR is the neglected lead. Similarly, the right ventricular infarction is the missed infarction when we talk about the diagnosing the right ventricular infarction. So in right ventricular infarction, what happens along with inferior ST elevation in the inferior leads, there is an ST elevation in V1, ST elevation in lead 3 more than lead 2, and if the magnitude of ST elevation in V1 exceeds the magnitude of ST elevation in V2, then we should think about the patient is having a right ventricular involvement also. And if the ST segment in V1 is isoelectric and the ST segment in V2 is markedly depressed, then also we can think about the RVMI. So in any scenarios, if the inferior wall ST elevation in the inferior leads associated with ST segment changes in the V1 more than the V2, then we should think about that this patient is having an associated RVMI. And the best thing to go or to read for this right ventricular infarction is to go for the right-sided leads. And it is almost the mirror image of what we do on the left side. The sensitivity and specificity of V4 right lead is about 88% and 78% in diagnosing the right ventricular infarction. And this is the lead which I feel in every case of inferior wall MI, this should be the right ventricular infarction should be taken into consideration, especially if the patient is having a low blood pressure associated with the inferior wall MI. The right ventricular leads should also be taken in an ECG. And the one lead which should be read thoroughly is the V4R. And you can see if there's an ST segment elevation, you can see there's an ST segment elevation in V4R, and ST segment elevation more than 1 millimeter, and there's a positive T wave. This gives an idea that this patient is having a proximal occlusion of the right coronary artery. On the other hand, if this patient is having, the V4 is having a isoelectric or the no ST segment elevation, and there's a positive T wave, this shows that the patient is having a distal occlusion of the right coronary artery. And if this patient is having an ST segment depression and the inverted T waves, and this is an occlusion of the left circumflex. So from the V4R only, we can locate the site of the occlusion of the inferior wall, whether it's a proximal occlusion of the right coronary artery, whether it's a distal occlusion of the right coronary artery, or it is an occlusion of the left circumflex coronary artery. This is what is the inferior wall MI plus RVMI. The ECG will be like. You can see ST elevation markedly raised in lead 3 more than lead 2. You can see the ST depression in lead 1 and AVL, in AVL more than lead 1. And you can see the lead V1, although there is no ST segment elevation in the lead V1, but you can see the ST depression. So if we compare the V1 and V2, the ST segment in V1 is higher as compared to the V2, signifying that there is the involvement of the right ventricle. So this kind of patient, because once the patients of an inferior wall MI have an associated right ventricular MI, the management changes. The amount of fluid you want to give to the patient, the inotropic support you want to give to the patient automatically change, and the prognosis also changes when it is diagnosed early. So in a patients of ST segment elevation and with having in lead 3 more than ST segment elevation in lead 2 and ST depression in lead 1 and AVL, if it is so, that means your involvement is of the right coronary artery, and the positive predictive value is about 94%. On the other hand, if there is, and in addition to these changes, you find an ST segment elevation in V1 or V4R or both, then again it shows that the patient is having a right ventricular involvement, also right ventricular infarction, and the specificity is 100%. On the other hand, if the ST segment elevation is more in 2 as compared to 3, there is no changes in the lead 1 AVL, then the chances of involvement of the left circumflex artery is higher. So this is again showing the same thing what I have already talked about. The ST segment more 3 as compared to the 2, ST depression in lead AVL more as compared to lead 1, and there is a significant depression of ST in the V2 as compared to the V1, more depression in V2 as compared to V1, suggesting the right coronary artery involvement and the right ventricular infarction. So after the right ventricular infarction, the other entity which we usually miss is the posterior myocardial infarction, and most of the times we miss it with the anterior wall MI. So it is seen about 15 to 20% of ST elevations MI, and it is a context of an inferior or lateral infarction. So the isolated posterior infarction is very less, so it is always happens in context with the inferior or the lateral infarctions. And isolated is very less, about 3 to 11% of infarcts, and posterior extension of an infarct means the more muscle is involved and more damage to the myocardium is there, and the increased risk of left ventricular dysfunction and death. So this is what we have. This is a change in the lead V2. You can see there is a horizontal ST depression. There's a tall, broad R wave, and there's an upright T wave. So this may give us an idea that this patient is having the non-ST elevation MI, or maybe the unstable angina, because there's ST depression in the precordial leads. But if we focus on the R waves, you can see there is a well-maintained R wave. So this cannot be the ST depression or because of the LAD. This has to be the posterior wall MI. And once we take the mirror image of this, we see it on the other side. You can see this is actually a two-wave. What we are missing, looking at it from the front, is the R wave, but actually when we see it from the posterior side, from the mirror side, it is actually the Q wave, and there's an ST elevation. So this patient should not be missed with the anterior wall, with the non-ST elevation MI or the unstable angina because of the LAD involvement, but this patient should be treated as an ST elevation MI, because the management changes, because the prognosis is altogether different of the two scenarios. And for the posterior leads, we need to take the the extra leads on the left side, and once we take those extra leads V7 to V9, then we can see that we are not missing the posterior wall MI. And this is what the posterior wall myocardial infarction seems like. You can see there is a preservance of the R waves. You can see in lead 1, V1 also there is a preservance of the R wave, and this is a R wave. This cannot be seen in the non-ST elevations MI because of the LAD involvement, because this is actually a Q wave, not an R wave, because we're taking it from the front. So the posterior wall MI should always be kept into consideration when you are looking for the ST wave changes like this in the mid-precordial or the anterior precordial leads. Then comes the lateral wall MI. So we have come from the anterior wall MI, the left main MI, then we have inferior wall MI, the RV MIs, posterior wall MI, and now we are coming to the lateral ST elevation MIs. So lateral MI can be produced because of the branches of an left anterior descending artery and the left circumflex. So it occurs as a part of the larger tertiary infarctions. We can have the anterolateral because of the LAD involvement. We can have the infralateral because of the circumflex involvement. And in lateral leads, we have the ST elevation in the lateral leads, 1 AVL, V5, and V6. And we can have the reciprocal ST depressions in the inferior leads, 3 and V5. So if the ST elevation is primarily localized to lead 1 and AVL, then it's a high lateral ST elevation MI. And in the beginning of the slides, I've shown the blood supply of the various parts of the heart, and the high lateral part of the the LV is supplied by the diagonal. So if there is an ST elevation in lead 1 and AVL, you should think that this patient is having a diagonal or D1 involvement. Reciprocal change in the inferior leads is only seen when there is ST elevation in leads 1 and AVL. So we can have the anterolateral. Lateral can be the anterolateral ST elevation due to LAD occlusion. We can have the inferior posterolateral due to the circocclusion, or we can have the isolated lateral infarction due to the occlusion of smaller branches such as diagonal and OM, or in some cases the ramus intermedius. So this is the ECG of a lateral wall MI. You can see 1 AVL. So there is an ST elevation in 1 AVL, and there is a reciprocal change in the lead 3, suggesting that this patient is having a the diagonal branches involved in this, because there is elevation in the 1 and AVL. So if you have an ST elevation in lead 2, 3 AVF, and it can be either the RC occlusion or it can be the LC occlusion. If you are not doing the right ventricular leads, you have not done the V4R lead, then if there is ST elevation in lead 1, then you should think about that the patient is having a right coronary involvement. If the ST elevation is there along with the, if the ST is elevated in lead 1 along with the inferior leads, then you should think about the circ. If the ST depression is in lead 1 along with the inferior lead ST elevation, then our right coronary artery is involved. If the ST in lead 1 is isoelectric and ST in elevation in lead 2 is more than lead 3, then it is in left circumflex involvement. If there is an isoelectric lead, isoelectric ST in lead 1, but there is ST elevation in lead 3, 2 is not more than lead 3, then you should look for the ST depressions in lead V1 to V3. If there is an ST depression, that is the posterior involvement is there, then it is L6 involvement. If there is no ST depression in V1 to V3 along with these changes, then the RCA involvement is not there. To make it much easier, it is always better to go for the right ventricular leads. And if there is a V4R lead and you have taken an ECG of that, and you see there is an ST elevation in the V4R, then it is a right coronary artery involvement plus the right ventricle. If there is T wave is positive, then it's a distal right coronary artery. If the T wave is inverted, so it's a left circumflex artery. So I feel what I want to infer here, or what I want to impress upon the physicians or our colleagues, is that once you are finding an inferior wall MI, it is always better to get the right ventricular leads done and focus on the V4. And if you have any of these three patterns, you can easily localize and you can easily prognosticate the patient, because right coronary artery with right ventricular involvement, it needs an urgent intervention. Distal RCA, you can wait. Left circumflex, it needs an intervention. So there are some scenarios where we have the simultaneous acute inferior wall MI and the anterior ST elevation MI. So that means that we have an ST elevation in the anterior leads, we have an ST elevation in the inferior leads. As I already discussed in the previous slides, that it can be either because of the wraparound LAD or it can be the proximal RCA occlusion. So clues to whether the culprit artery is proximal RCA or wraparound LAD, it includes ST elevation in lead 3 more than 2, it suggests the proximal RCA involvement. ST elevation in V1 more than V3, it suggests the proximal RCA involvement. And if there is a progressively more ST elevation as one moves from V1 towards V4, it suggests the wraparound LAD. So this is the one thing which helps you in differentiating whether the the elevations in both is because of the RCA involvement or because of the LAD involvement. So as in the beginning of my slide, presentation, I showed the slide that we should be more focused upon we should correlate it with the clinical scenario. So there are non-coronary causes of the ST elevations, and there are n number of causes. You can have the ventricular aneurysm, pericarditis. I don't want to go into the detail because in these scenarios you cannot localize the vessels. So the only few things I want to discuss here is that the left ventricular aneurysm, because in almost in 100% of the case, the left ventricular aneurysm is because of the acute infarctions, and once the muscle gets dilated, the LV gets dilated and goes into the aneurysmal dilatation. So if there's a persistent ST elevation more than 2 weeks, you should think about the left ventricular aneurysm. Some degree of ST elevation remains in 60% of anterior MI and 5% of inferior ST elevations MIs. So the cause of this aneurysm is incomplete reperfusion, or the patient has a transmural scar formation following an acute MI that causes the dilatation of the territory. So it can be because of the cardiac infections also, cardiomyopathy, and congenital abnormalities also. So how to differentiate it from the acute MI is that if the ST elevation is more than 2 weeks following an acute myocardial infarction, so again the history comes into importance here. It is most commonly seen in the precordial leads. So aneurysmal dilatations you can see mostly in the precordial leads. It may exhibit a concave or convex morphology. It is usually associated with a well-formed Q or QS waves. And the T waves have a relatively smaller amplitude in comparison to the QRS complexes. So this is how we can differentiate an old, because your aggression, your treatment, and your intervention all depends upon whether you want to take that patient at that point of time or you just want to do the viability test and then do the intervention. So this is important to differentiate from the acute MI. cases. So this is how you can differentiate an acute MI from the aneurysm, by looking at the ratio of the T wave to the QRS complex amplitudes. If the ratio of T wave to QRS ratio is less than 0.36 in all precordial leads, it favors an LV aneurysm. So this point should be taken into consideration. And if the T wave by QRS ratio is more than 0.36 in any precordial lead, it favors an anterior ST elevation MI. Because just by calculating this ratio or calculating this parameter, you can just think about whether you want to take that patient into the cath lab urgently or you want to go for the viability test. If the score is more than 0.36, it is better to take the patient in the cath lab and do the procedure. If it is less than 0.36, it is already aneurysmal, do the viability test and then think about what is to be done next. Early repolarization, Dr. Vanith has already discussed about. Pericarditis, I don't want to go into much. The only reason I want to mention why I have kept this slide here, because you can see a lot of, the ST elevations in the acute pericarditis depending upon the stage. And this is the one slide which can help us in understanding the difference between the ST segment changes in the acute pericarditis, myocardial infarction, and repolarization, because my talk was limited to this myocardial infarction and the ischemia only, so I have focused here only. The other thing which I want to talk about here is about the Stokosova cardiomyopathy. Again, you can see there's an ST elevation here, and to be missed for the acute myocardial infarction. There's a clinical criteria for this. New ECG change or ST elevation or T wave inversions or moderate troponin rise can be there. There occurs a transient akinesis or dyskinesia of the left ventricular apex in this cardiomyopathy. And once you do the coronary angiogram in these patients, you may find that the patient has a normal coronaries or a non-critical coronary artery disease. So this is one of the ECGs which also should be kept in mind when you are dealing with the patients who present with the chest pain and you have a normal coronary. So this can be with the entity what we call the Stokosova cardiomyopathy, and it will not help you in localizing. At a first instant, you can see that this patient is developing a right bundle branch block, and maybe this patient is having a proximal LAD occlusion. You take the patient into the cath lab, and surprisingly, you do an angio and you find everything is normal. So this should also be kept in consideration.